how to manage a critically unwell surgical patient. You will always find an unsatisfied consultant. The examiner is like, okay, what's next? I will go and see this patient using the ABCD approach. Then he's not satisfied because, as I said half an hour ago or 5 minutes ago, you are the only registrar or the only man in the hospital managing the whole department. Your nurse could be sleeping, your SHO could be in a restaurant having his coffee, and your consultant is in a conference or sleeping or it's night, okay? So you are responsible to awake the whole hospital, okay? So you need to go, number one, do SPIES. SPIES is scenario identification, patient safety prioritization, I initiative, which is ATLS, ACLS, or CCrISP approach, and then E escalate, and S support your senior members of the team. Number one, C, like this case is a critically unwell surgical patient. So number one, you need to say 2 lines. No surgeon will listen to you more than 5 minutes. This is like, you can't talk a lot and give, you have to be organized. Okay, perforated DU patient or acute abdomen case or major post-abdominal abdominal surgery, and you are expecting major complications. So you need to say, this is a critically unwell surgical patient who could have surgical reasons and non-surgical reasons. Surgical reasons could be anastomotic collection, surgical site infection. Non-surgical causes could be PE, MI, pneumonia, UTI. So this is hemodynamical unstable patient requiring specific investigations to reach a specific diagnosis that could be surgical. Okay? So I need to prioritize this patient for patient safety. I need to see this patient first and by myself. Excellent. Now you take box number 1. So you are alert that this is a critically unwell scenario. Okay? So then I need to escalate this to my consultant, on-call consultant, and my senior members of the team and other relevant teams, organizing local MDT, including talking to Anita test regarding patient fitness for surgery and comorbidities or morbidities and mortality, and talking to ITU registrar for bed availability and if ITU is required. Okay? Then you have now used the available resources effectively. You have a consultant updated and you have local MDT, then you have theater nurse and ward staff nurse, and you have radiologist. Okay? So you need to talk to the radiology consultant, okay, like this. I will talk to the radiology consultant if required for ordering CT abdo-pelvis with contrast. We know that this case, like, don't say ultrasound. This case is perforated DU or something risky. They are telling you patient is diabetic and his abdomen is tender all over, and some people will tell me, Reda, are you sure? Are you going to request CT scan? This is, you are telling your thoughts to your examiner, but you are not going to talk to the consultant before you make sure. But you are telling your anticipations and your alertness to your consultant, so that you are alert, you will do it. Okay? So you need first to see your patient, and by myself and blah blah blah. You need to inform your SHO to come and see the patient and investigate or initiate the initial management, which will be asking the nurse staff to get observations and your if I want to start ABCD approach and getting bilateral 16 gauge cannulating if required. And then you go and see the patient first and by myself in a safe environment and start my initiative, ensuring closed loop communication, and every one of the team members are aware. Now, your consultant discovered that you are able to pass MRCS OSCE. Not by saying everyone will say airway patent, patient communicating, then high flow oxygen 15 liters per minute. Everyone will say that. But not everyone will be alert about like NHS case. We do this in Northampton, in Scunthorpe, in Wales. Everyone do this. Okay, so it's not important to say A, B, C, D, E, but it's important to do this. Awake the whole hospital around you. Then that's anticipated from you. See your patient, airway. If the patient is talking well, then the airway is patent. I will give 15 liters per minute oxygen, ensuring that the patient got no COPD. Otherwise, I will ensure the target is 88 to 90%, 92%, and using 4 liters per minute via venturi mask. Okay, good. Then I will proceed to breathing. I will look for use of accessory muscles of respiration. I will count respiratory rate, equality, and depth of respiration. And I will auscultate for any abnormal breath sounds, heart sounds, for rate and rhythm. And also, I will look for any signs of overt or covert bleeding, and I will start to ask the FY1 or SHO to put bilateral 16 gauge cannulae, wide bore cannulae, to take and give. Take what? Don't say routine bloods. Full blood count, usually CRP, amylase, glucose, clotting profile, group and safe, cross match, and activate massive hemorrhage protocol if that's required, of course. Then arterial blood gas, lactate, 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 lactate. Okay? Then I will give IV fluids, stat dose bolus of 40 ml per kg. 20 ml per kg if the patient is hypotensive, 10 ml per kg if the patient is normotensive, and 5 ml per kg if the patient got any element of heart failure. Excellent, good, good. Then you have taken and given, good. Then I will ensure surviving sepsis 6 bundle being done. Oxygen I gave, fluids, broad spectrum antibiotics according to the local hospital guidelines, blood culture or urine culture and surgical site culture if required, and urine output monitoring. Patient should be MPO, total input and output charts, and ECG. Okay, good, good. Capillary fill time, signs of overt and covert bleeding, and check tubes, lines, drains for nature and volume. Okay, okay. C, done. ECG done. Portable erected chest X-ray in breathing done. A harvest news score. Then go to D. In disability, Glasgow GCS or AVBU. AVBU, alert, verbal, pain, or unresponsive. Done. BM, what is the blood glucose level of the patient? Okay, blood glucose level, and also I will need to have review for the anesthetic charts, analgesic charts, and any medications that could affect the patient dysfunction of CNS. What else? Then I will ensure patient got adequate analgesia. Then move to what? E. Fully expose the patient, ensuring his dignity, doing quick abdo exam, and look at squeeze the cuff, look for TEDS, any lower limb edema, and also have a quick look at the abdomen for any signs of peritonism, any surgical site infection, dry dressing a clean wound, or soaked dressing, and could be surgical site infection. And also bowel sounds. When last bowel opens? That's important question also. Last bowel open. Okay, so you have both NG tube as well in C, both urinary catheter in, and you have these tubes, you have total input and output charts, you are controlling your case. Okay, E, ensuring that the patient got no fever and no hypothermia, and use warm blankets if it's ATLS more or less. Okay, and that's it. ABCD approach, ensuring that the patient stabilized before moving to what's next. If not stable, I will repeat ABCD approach. Excellent, good, happy, say happy, happy, everyone happy, okay. Then I will ask now for chart reviews. Charts, what charts? Antibiotic, medication, IV fluids, analytic charts. OP notes, patient whole notes, GP records, any recent scan, endoscopies, any MDT outcome. MDT outcome. Then I will assess the patient performance status, frailty, in a joint decision with the ANISA test, and the consultant will have a decision regarding whether it's active treatment, active conservative, end of life care, palliation. In case of palliation, we need palliative team, pain team, nutrition team. Okay, good, good. Then I need to explain these findings to the patient and patient next of kin, ensuring that we have a joint decision in the patient best interests. Good? Everyone is okay? Then if the patient got capacity, then consent form 4. If not, then consent, if patient got capacity, consent form 1. If not, consent form 4 with 2 consultant signature, ensuring that the patient got no advance directives, no lasting power of attorney, no independent mental capacity advocates, and ensuring that I have idea about the patient wishes and like past wishes and the future, or past background and the future wishes. That's it. Okay? So you have done everything. For any case, this is a general scheme. For example, PE, how to manage. Okay, CTPA, and then I will talk to hematology. I will talk. Patient EGFR is not okay. So I will talk to the radiology consultant, ask for, don't say CT. CT what? CT abdomen. What abdomen and what? Abdomen and pelvis. No. Complete answer for the consultant, not to something. Anyone here? Prompting. Prompting is when a consultant helps you, he will take mark from you. So be aware of prompting in ST3 and in MRCS. Prompting means that I will take mark from you because you don't know, and you are my rule, you are my arm. So prompting means that I will help you, but I will not give you the mark. Okay? So I will ask for CT abdo-pelvis with contrast, ensuring that the patient got no contrast allergy, and EGFR is reasonable above 30. If not, I will talk to the renal team to adjust or to optimize the case for us. Okay, patient on warfarin. I will talk to hematology regarding reversal, PCC and FFPs. Patient non-AF. I will talk to cardiology and medics if available, for what? For echo, ECG, and reversal if or anticoagulation versus reversal according to the patient anticoagulation status. Patient COPD. I will talk to respiratory team. I will ensure patient stop smoking pre-op and ensure physiotherapy, pain management, and ensure that we do physio pre and post and optimizing the whole case. Okay, patient on steroid. I will ensure that the patient, if he got 10 milligram recent 3 months, I will ensure that steroid cover is there, talking to the ANISA test, minor, major, moderate, minor, moderate, major. Minor, how much? 10 milligram hydrocortisone at induction plus the preoperative
25 at induction. 25 at induction with usual dose.
25.
Yes.
Yes, 25. Okay. 25 milligram hydrocortisone.
Yes.
This is what we said yesterday. Excellent. And if moderate, the usual preoperative dose plus 25
plus
milligram hydrocortisone plus 100 per day, 100 once daily, per 1 day. If major surgery, then usual preoperative dose and 25 milligram hydrocortisone plus 100 milligram
for 2 to 3 days.
For 2 to 3 days. Excellent. Okay. So now you have understood the whole scenario. You shouldn't do everything alone. You should talk to the radiology, talk to hematology, talk to medics, and once you finish, you say, okay, this is abdominal sepsis acquired cause, CT been requested. Okay, this is the CT results. What? Okay, there is AF in the ECG. So I need the available results, including routine bloods, what I asked for, and lactate, ABG, and
Arterial blood gases.
ABG, yes, and ECG and the chest X-ray. Okay, ECG, AF, absent P wave, irregularity. What are you going to do? How to manage AF? What is the reason for AF? Okay, reason for AF, sepsis, electrolyte disturbance, and it's multifactorial. Okay, so you need to do this. Okay, thank you so much. And we have finished how to manage any critically unwell surgical patient, general scheme. You customize, that's it.